Welcome to another episode of the DIDAS Health Working Group webinar. We have a special guest today. It's Ernst Hafen, former professor of the ETH and now the president of the Swiss Health Data Space. And he'll present his current activities to us. Ernst, thank you very much for taking the time and for joining us. The floor is all yours.
Well, Pete, thank you very much for the invitation. I'm very happy to be here. Our claim is data to the people, to empower people to control their own personal data, because I think for us, and we all share this vision that the digital transformation of healthcare has to be human-centered, the human in the center. And this starts already with your genetic or genomic data. We are all different. If we look at the left-hand side of the picture, and this is in part based on our difference in the genome, and we differ amongst each other only in 1 in 1,000 base pairs. That's all. But that makes this that is the basis for this difference, because if we had identical genomes, like in identical twins, this is the result that we see here. But even identical twins, the older they get, they differ. So your genome is not your destiny, but it is the basis on which you can develop, and the environmental factors play an absolutely essential role. And it is so important to get all these relevant data together. And it's only humans who can do that. We often compare that to Google Maps. In Google Maps, all the data are integrated based on longitude and latitude. That's how you find the entrance to your favorite restaurant. In health, the integration point is the individual human, from his genetic data to his mobile health data, his clinical data. That has to be integrated over time. And obviously only humans have the right to obtain copies of all their personal data. No one else has that, neither Google nor Apple. And they can control access to this data. And structured health data is an absolutely essential commodity for the personal and public health. And so that's why we're convinced that we have to empower people to obtain and control their personal data. Much in the same way they now control their financial assets. We all do e-banking. The economy works because we invest and spend our money differently. And we have to go to the e-banking of health data in the same way. Currently, this is not possible because the infrastructure is not there and the mindset is not there. And that's where our association, Swiss Health Data Space, wants to work towards. We're an association, we're independent, we're not building any software product. We are promoting this vision of this human-centered transformation, where I, with my data account, are in the center. I order all the data from all the relevant stakeholders into my data account in a structured format, and I decide which data I can share in a health data space, which is analogous to the European health data space. Our association wants to make this vision public and promote this vision and define the operational criteria, what is needed for the trust in this Swiss health data space and in the personal health data account. Now, obviously, this is not a very easy task. We all know that. We are all for more than 10 years in this space, and we have all the obstacles. Now, this is a way to look at the healthcare system currently. There is absolutely no logic in this system. And even though the patient is at the center, he is clearly not empowered. So we decided, under these circumstances, we have to do something different. We have to walk the talk. We cannot write any more white papers. There's enough written about this. We want to test the current system. And that's why we decided to plan an expedition. And an expedition into outer space is done with dedicated astronauts. It takes a lot of money and it's hard work. And so is an expedition into the health data space under current condition hard work. So we need experts, we need dedicated people. We call them Salutonauts, citizens, patients who want to take it on themselves to do exactly that, claim their data, structure the data, test the current infrastructure, and share the data. We need Salutonauts and Mediconauts, or medical professionals that share the same vision, achieve this digital transformation. And so what we do on the expedition, we collect a defined set of data. And we, that is the individual, we as an association don't see the data. The individual is in charge of their data, and they deposit in the relevant health data repositories that are available. So we start with a structured health check that already results in structured data. Every Salutonaut is doing that at the onset of the expedition. The Salutonaut is then requesting his health data insurance data, from which we can extract when he interacted with the healthcare system, what medication he has taken, and why he interacted with this. From this, you can then also request the doctor's data from the doctor itself. We request vaccination data, laboratory data, and mobile health data. And so each Salutonaut has ultimately in his data account all these different sets of data together. He tests with these data the current APD versions, 1 or 2. He tries to switch if he wants to. I'm trying to do that at the moment, but also private providers that provide health data accounts in which you can upload data. And at this stage, we're not sharing any data, and we're not interested in the data themselves. We're interested in the experience. So all the Salutonauts are connected through a logbook in which they report their experience. How long did it take to open an APD? What could you do with the APD? What could you not do with the private accounts? How did it take for the data from the health insurance to come to you, in what format, etc.? This is the information that we collect and that we then publish and feedback to the providers of these different infrastructures. Every month, we have a digital meetup with all the Salutonauts where we discuss different issues, feedback the information, and we see that this is a very active and very interesting group of people that we get together to brainstorm about new solutions. In the second part of the expedition, once we have all our data structured, we should say that we are working together with companies to help us to structure the data that come in unstructured PDF formats. I can talk about that later. We then take our data and we test the current infrastructure of the data spaces that are available. The SPHN models, the FinData models, and other models that are currently in development. Because we have a unique set of data that we, as Salutonauts, agree to share in these different infrastructures to see how they respond, how quickly they respond, what is the governance of the structure, how can we improve the governance and security. Of course, we always have an eye on the development of the European health data space also. So a word to the comprehensive medical examination that we do at the start. This is the system that was developed 10 years ago by Barbara Biedermann, who is the primary Mediconaut in our expedition, where she has found that if you structure the first interaction that a family doctor has with a patient, with the family history, his past ailments, etc., in a structured format, you can actually gain a lot of insight into the health status of this particular person, present and in the past. And these are 7,000 data points that you record in a structured format. And that is clearly a human-centered view, how the medical doctor sees the patient. That's why we, and thanks to Pete, we had a contact to the organization of OpenEHR And we see so many parallels between this comprehensive bedside diagnosis, the way Barbara models this human, and the way OpenEHR models the human data structure. And we're currently testing how we can actually integrate the health check into this OpenEHR framework and test it on our expedition as part of a sort of a model for an EPD 2.0 or 3.0. And this is basically what our vision is. Citizens and healthcare professionals work together. This has not been the case now. No one wanted the EPD. Now we have to have the primary drivers, the citizens and the healthcare professional work together. EPD 2.0 will contain all the health data in a structured format from cradle to grave. The once only principle works. OpenEHR could be the common language because it's open source, it's not vendor dependent, and it's of course the citizen who is in control of primary and secondary use. And in this way, all the participants will benefit from this new health data ecosystem. The advantages, we don't have to go through this in detail, but the human-centered model is absolutely important. OpenEHR is an international open source and vendor-independent standard, so there is no lock-in like with other vendors. If the citizen is in charge, patient-reported outcomes become a matter of a smartphone click. Quality measures are available, so you can really shift from treatment to outcome reimbursement. The once only principle guarantees cost savings. There's a study talking about 8 billion in Switzerland that can be saved. And it is the basis for a functional and fair health data space in which the real world data can actually be used for research and for primary care at the same time. So this is our vision. Where is the expedition at the moment? We envision to have 500 Salutonauts. Currently, we have 80 Salutonauts that have signed up. 30 have started the expedition. We're sort of constantly expanding the expedition. Now we have the City Hospital Triamli and ETH are now hubs for Mediconauts, where these structured health checks can be carried out. We have incoming ETH medical students that are encouraged to participate in the expedition as of the fall this year. ETH will cover the costs. The participation in the expedition costs 500 francs for every Salutonaut. This is partly because the health check is reimbursed by the doctors for 350 francs, and 150 francs is the membership to the association, and ETH will cover the cost for their students, because students will now learn with their own data during their education. And we form this alliance of change makers, entrepreneurs, healthcare professionals, and patients, and we already have several companies with which we collaborate in transforming the analog data into digital structured data, including AI-based solutions that allow us to record the health check in dialect, directly translated into High German, and extract structured values from it. We're planning a clinical study on this together with Triamli. So all of you, of course, are welcome to join the expedition. We need all of you. We need the first movers, and we'll be happy to come together with you. On June 26, we have our second forum, where we look at the healthcare system, at the present healthcare system, really from the citizen, from the patients. We have 2 patient advocates. We have Aurelia Scheiwiller, who's the president of the Medical Student Association in Switzerland, and she will report on how little she learned about digitization during her education, and how difficult it is for an assistant doctor at the moment to do nothing but collect and transcribe data, and she's probably quitting her job after obtaining the FMH. And Franz Grüter, who's also president of the Paul Tligi Association, will also report. in addition to the Salutonauts that will report on their first experience. Our vision is this human-centered digital transformation. We can only achieve this by actually doing it and by having the first movers who go through the work and improve the system as it is now. So I hope you will join us for the forum on June 26th, and of course also join us on the expedition. We'll have a very exciting group of people here that can move the system forward. Thank you very much for your attention.
Thanks a lot, Ernst. That's really exciting news. I love the idea, of course, as you can imagine, and I'm already registered for the event. Two things which I would like to add before we go into the questions and discussion. The one thing is talking about the open air. I want to recap a few discussion points from the last session. So there was initially a discussion about the Swiss finish, and after some back and forth, there was a wide agreement that we definitely should not do a Swiss finish, but rather use the existing international standards. So it's really independent and it's vendor independent. I think that's one of the cornerstones how to move forward there. And the second thing is, why are we as DIDAS running such events and in the healthcare space? So Ernst was talking about EPD 2.0, which will be based on structured data. We are even envisioning EPD 3.0, which will be wallet-based. That's actually our background. And that's something what occurred to me in a hackathon where we submitted a challenge. There is a different culture how to go along with healthcare data. The DACH countries, Switzerland, Austria, Germany, they are very reluctant to disclose personal data, while the Nordics are much more pragmatic in this area. And that's also the reason why they are more advanced in digital systems. But if you think about the wallet-based solution, that's really where from a technical perspective, the citizen has the data under his control. And I think specifically in our culture, that's a relevant element. And we are currently prototyping this EPD 3.0 version, basically a follow-up project of what we did at the challenge. So I think the pieces fall into place now. And I think we have an opportunity to contribute with your activities, Ernst, and also with the activities of DIDAS. So with that said, I would like to open the floor for questions and discussions. Are there any questions or other contributors? I have a few ones to start with. You're mentioning you have these monthly calls where you exchange your experiences. Is this just the participants, or are you already inviting solution providers as well?
Well, both, because the solution providers realized very quickly that the best way to find out about what's happening is to become Salutonauts themselves. So we have Salutonauts from Sanela Post, from Abilis, from health insurance companies that employees, they participate. And of course, in the first meetings, the first ones were the ones from Sanela Post. They get, of course, a shitload of complaints of how difficult it was and so on. And so we had to steer the thing away towards sort of the changing the system. But they're taking up these criticisms, of course, and try to change as fast as they can. But in general, it's not just the complaining. That's very easy. We all know how difficult it is, but actually to come up with solutions. And this is, we've discussed this before. This is also the case for the Impfdaten that Meine Impfungen now released, and that is so horrible to import it. You should be able to import it into your EPD. And Barbara was doing that herself as a medical doctor, and she realized that it was all wrong and duplicated, and the data in her INF registry said that she had hepatitis B as an illness, which is not very nice to have that in your record. But actually in the Impfbüchlein was that she had an Impfstatus of, she had a resistance to hepatitis B. And to release something like that is, I mean, not criminal, but it's dangerous, right?
You are bringing up an extremely important point. It's about data quality. So structured data and standards is definitely one important ingredient, but if the data which is inside that, be it structured or not, is not correct, then the system loses all its trust.
But that's why I think the point that for this transition to work, that medical doctors and healthcare professionals and patients work together is so important, because especially the informed ones that are now engaging in this, from the Mediconauts and the Salutonauts, they can exchange at eye level, and they can say, hey, you know, my birth date is not 65 but 56, and the doctor can say, no, this is actually not what the AI solution meant, etc. So you increase the quality of the data jointly.
Absolutely. And you're making another important point. So most of today's digital systems in the healthcare sectors are designed and built by, forgive me the word, IT nerds. So they may be good in certain things, but most likely not in clinical things. So it's absolutely important to have the clinical specialists on board. And just on that note, Ernst, you know it, we are working with the University Hospital of Basel to find a way to exchange data between the hospital and the general practitioners. And we had just yesterday a call, and talking about this open air, there is one person in Switzerland who is extremely knowledgeable in both worlds. It's Amanda Herbrand. So she was part of this pilot, which University Hospital of Basel was running. And we yesterday discussed that as a first step, we need to define the relevant data points which need to be exchanged. And although I'm very interested in that, I told them it's really very important that you are doing that, but I can listen in, but I, as an engineer, I can definitely not contribute. So that's something what needs to happen between the medical doctors and the clinicians. And once they have defined what the data points are, then the technicians can build the solutions. And the really nice thing there is the medical doctor, the practitioner who is contributing, he comes from IT. He was an IT guy before he became a medical doctor. So he knows both worlds, which is very valuable.
Yeah, and he is our first Mediconaut in the Basel area, right? To Dominic and to Fabian, and one thing that is very clear, that the group that we are having is actually an extremely good beta tester group. So if you have something, if you have your data accounts or so, just give them a try and come in and present in one of those weekly meetings and get feedback, and people can try that out. So beta testers for, and I'm in the case of the vaccination data, but with the APD, and there's going to be a nightmare with the insurance data, because people will send paper PDFs or not send the right documents. And then I stopped. But we were in Geneva yesterday and with Paul Olivier Dehaye, and he said he wanted to get his data from Swisscom, just the mobility data. And he got it, but he said the Swisscom guy told him that for every person that requests their Swisscom data, that costs Swisscom 2,000 francs. 2,000 francs per person. So think about 2,000 people requesting their data from Swisscom, and this is where we are seeing our association after the first step. If we can obtain a legal delegation that we, in response to you guys, go to your insurance company and say, we're mandated by Dominic and Fabian and Pete to request your health insurance data in this format. Here is the legal document. Then we can get sort of this class action movement going, and that will transform the system very quickly.
I discussed pretty much this idea with André Gollier, who is the president of the Swiss Data Alliance, and we had the idea to prepare a letter, which not everybody has to write his own letter. Basically, it's a class action letter which everybody can send in, which forces the organizations to organize themselves to provide the data in a more efficient way. If one person does it, then they can do it 2,000 Swisses. But if you have a few thousand, then you need to think about your process.
I mean, of course, the form letters are on our website on the Explorer page, where you can also use this form letter to send it to your insurance company. Yeah, but doing it actually, if you're not part of the expedition, but if we have a service on the website where you can just say, yes, I want that DIDAS requests my health data, then that is, of course, a lot easier. And then a lot of people will want to have that, especially if we can then send it back in a structured format through our company contacts.
Excellent. Dominic has a question for a long time. Dominic, over to you.
So yeah, but in the meantime, I had a couple of leads to make remarks on other points as well. So in terms of structured requests sent to health data holders, so that individual can request their own data, that's going to be part of what we will be offering to our users. So I can see an opportunity for collaboration on that there. I think I'd be more than happy to join your next meeting. Unfortunately, I can't, as a side remark, because I have a conflict. I wanted to basically ask a question about the 7,000 data points of an initial assessment at the doctor's office to record, let's say, a baseline, and linking that with the other remark that health professionals today are doing nothing but recording data. To my knowledge, let's say much of that effort is not reimbursed, so there is little incentive for doctors to do that in the first place, which is why they stuff it on the overworked and underpaid these type of tasks. I struggle with the concept to have, let's say, medical professionals to go through a formal assessment to generate data for the sake of generating data, rather than directly focusing on the clinical treatment, which is at hand, typically giving rise of the visit. How do you balance this in such a setup? How do you motivate doctors to participate those data points? Incentive seems to be missing.
Well, yes, the incentive has been missing. That's why Barbara has developed this 10 years ago, this Cobedia's comprehensive bedside analysis, is nothing what a doctor does normally anyway. When you go to the first family doctor, he basically writes this down. It's just not structured. And she does this in a structured way, but she tried to convince other doctors to use this, or PIS providers to incorporate that in their PIS system. And for the last 10 years, she has not been very successful. Now things are turning, partly because of the Mediconauts that are really interested in this. Now the Triumli head of internal medicine is very interested in using this system now also for their clinical practice, because they say, hey, this is really, I can compare really different data sets with each other. And so the tide is turning slowly. And the other thing is that we're working with this company, 44AI, an ETH spin-off company that was just started. They don't even have a website yet, but they come out of a bigger company who's also a partner, Cuevita, in the sports data for Migros and Data Sport, etc., offering software like apps like Running Coach and so on. So this is Janni Schönleber is he will present at the forum. In the forum, we have an innovation lab now with 12 different companies that will present their solution. And Janni Schönleber, as a PhD student at ETH, developed a large language model in which he records the conversation between doctors and patients on the smartphone in dialect. It translates it automatically in High German, extracts the data, structures it, and writes a report all at the same time. And he has demonstrated that, and he's going to use this now. We're going to use this now for our comprehensive health check analysis, because it's a perfect example where you have structured data, and the doctor and the patient can look at it. And the unique possibility here is that this is an empowerment of the patient. So the patient goes to the doctor and says, "Would you mind if we record this conversation? And at the end, I will show you what the large language model has actually done to write a report on what we discussed for me and for you." And so actually that is really empowering, because how can the doctor cannot be against this, right? But he has a chance to then correct it and use it. So I think this is an interesting angle for the citizen empowerment.
Interesting. I would think there may be some reservations on the doctor side in terms of trying to avoid liability of being recorded in all their conversations. But as a concept, I think it's interesting.
Yeah, we have the same type of discussion. The doctors are a person of trust. They're very careful in taking on new things because they have this reliability issue. And you can hear that in many podcasts. For example, Germany is coming along with this DIDAS, and that's exactly the point. So the doctors are very slow in adopting these new technology as long as they're not sure if it's really reliable, because of course they don't want to take the risk to make incorrect statements. But that's the point which we really need to bring along, because everybody is in favor of AI these days. It's a real hype and everybody is afraid to lose the job. But I personally think I will not see in my lifetime the day when this works without the human in the loop. So you always need some critical thinker in between. It's quite impressive what you can do with AI. I was just supporting a master student with the AI work. If AI is not sure about the facts, it starts to hallucinate. And honestly, I don't want to have a treatment based on the hallucination of an AI algorithm. So I definitely want to have the doctor in the loop there.
That's why the patient and the doctor in the loop in something like that is absolutely essential, and the system will learn.
And the other thing is that where AI is really good at pulling together the information. So once you have the data in a complete and structured form, it's quite easy to do all these lookups, which would normally take quite some time for the doctor. So the recommendations can be presented much quicker than it can be done these days, but it's at the end, it's still the medical doctor who is in charge of making a decision. So I wanted to make another point. So looking forward to your forum on the 26th of June, I think we are seeing a new generation of young doctors, digital native doctors. And I already mentioned that to I think Valeria, she's the president, that I think they grow up with these digital means and they have a totally different approach. So the more senior practitioners, in their education, they never heard about it. And that's changing right now. And I think that's very promising, because they will expect actually that they will have these means for their work, and they wouldn't go to a hospital where such an environment is not available. So possibly from this side, this will hopefully drive the change a little bit faster. Excellent. So any more questions?
Ernst, are you open to consider new organizations that they interface between the Salutonauts and the Mediconauts as well? Because
yes,
obviously, since you're not building the platform, you need people or organizations that
build the right platform. No, absolutely. Yeah. I mean, that's for you, and we can, whenever you're ready, we can set up a call with Peter Grollimund and Jörg Bühler, and offer it to the. We're still at the very start of the expedition, and people are building, testing, so it's really good. Absolutely, yeah.
I think the expedition is really the right way to go. Trying out things. So unfortunately, the official organizations, they are they prefer to have 5 more studies than taking a decision and doing something. And you only get the practical experience if you try it out. That's actually also what we did at the University Hospital of Basel. So we tried a few things and then made a decision what would be the best way to go forward. So I think that's really promising there. Excellent.
I have another question, if you don't mind. Much of the data that you want to share, well, obtain and then share with other doctors, as you outlined, would actually be qualified as primary data, intended to be used in clinical decision making. So I'm wondering whether you are, or how you are addressing the reliability of that data in the whole process. How do you ensure that the Mediconaut, a doctor on the receiving end, can actually rely on the data that they are being shared with? So like the hepatitis case, you want to avoid that.
Yeah, exactly. So we offer a solution with a company called Sense System, who comes from the insurance company side, who's been specialized in scanning reimbursement claims. And with them, we have a application for the Qualitätskommission EQK, and to scan the Impfbüchlein, also the yellow Impfbüchlein, and extract the data in a meaningful format. And of course, this can then be cross-checked with the Mediconauts, so that that not the same thing happens that now happened with meine Impfungen and Abilis and so on. So having the Mediconaut, the specialized sort of doctor that accompanies the exhibition in the loop, is a certain reinsurance. If you come to if it goes to the insurance claims and you realize that 10 years ago you have been to an orthopedic surgeon for your knee, then you have to ensure that the insurance claim is scanned, and that gives you just a time point when you had this orthopedic surgeon. You then can send a request to this orthopedic surgeon and request the data from him. But it's still primary data. It's whether it was correctly probably written down, not in a structured format, but our expedition, the primary goal of the expedition is just to go to the ICD-10 codes in the reimbursement claims and the medication data that is sort of prescribed, that is in these claims. That's where we go. We don't go further to the mandatory. We don't go further to the doctor's reports.
I'm thinking also of another dimension. So you, by quality, you refer to errors in the processing of the data. But I think there is also a threat of, if you have data in the patient's or individual hands, that data is altered deliberately. If you can change your own medical record, you may take advantage in various ways by presenting matters different than the facts. Being a health status for a particular profession, exposure, being for gaining insurance. So the question is also about verifiability and authentication of data, probably down to the line of having it signed by the originating professional rather than the individual in the process. Any thoughts on, or even any implementation of concepts like that?
Yeah, I think that's what Pete's wallet-based system is addressing. And of course, now if you just have a PDF, in theory, you just have PDFs that are sent into the system. But most of our PDFs we have to upload ourselves, and God knows what you do with these PDFs. But Apple Health already has the situation that if you're connected to healthcare professionals, You can get the data, but you cannot change those data. You cannot do anything with these data. They are just there. You cannot change them. So Apple does this, and the APD 3.0 will certainly have to ensure that this is also the case. And I mean, there was this other discussion that people exclude data because they don't want to have their sexual disease data shared, and which can cause problems. This is also something that has to be addressed.
I would like to come back to this point. So I think that's exactly the idea behind EPD 3.0 and wallet-based, because it's digitally signed. And you could even do that today with PDFs. You can digitally sign PDFs, then you can see if it has been changed. But the disadvantage of a PDF is you don't have structured data. And the verifiable credentials, which are being used in the wallets, is structured data, which will be cryptographically signed. And by the medical doctor, he's obliged anyway to do an anamnesis, and with a world where he can confirm in a reliable way that it is his statement and not somebody else's change in the data, then is a much more reliable way to have a good data quality at the source. The other thing about this famous Impfbüchlein import, I think this is more a processing issue. So I would very much assume it's incorrect data import. So somewhere hepatitis popped up, and instead of taking that as a vaccination, it was taken as an illness. So and that's again a problem if you have IT nerds without the clinicians who do the reality check if that is reasonable data. So you have both dimensions. You have the verification at the source and you have the processing. But if you're doing capturing data in a structured way at the source and digitally signing it, then you can avoid many of these processing issues, because you just pass it on as it is, as a signed digital record. And that's exactly the prototype which we are now building. So the very first prototype was demonstrated on these hack days. So there is a video which shows how that could look like. Of course, within these 30 hours, they had to take a lot of simplifications. But the next step is actually that we bring that on a more professional level and as a demonstrator. And the idea is to demonstrate it to both communities, to the SSI community, which is very interested in the technology, but not so much in the use case. And on the other side, to the clinical community. So they are interested in the use case, but not so much in the technology. And it's actually the idea of this prototype bridging the gap. So it's still a prototype. You cannot use it today in a production way because the technology is not yet ready for prime time. But once the digital identity of Switzerland comes along, the infrastructure would allow for such services. That's why we are starting today.
Ernst, Ernst, a quick question. This service of vaccination card verification or post-process verification of vaccination cards, is that a service that you are operating in this Mediconauts journey, or is that not a service?
No, that's a service that we're operating in this. We are doing, and this is the service we will be doing independent of whether we get the funding through the EcoCar Foundation, and it will be a service that is then also offered to the APD providers to incorporate that into their APD. So it's something that is not exclusive for us. We want to develop it together with this company for public use.
Okay, interesting.
Quickly talking about the current EPD situation, I think everybody is aware that today's EPD has never been built for such solution. It's very document oriented, and they are now trying to put something on top for which the system was not really built. And that's one of the contributors to all these challenges which we have today. And that's the reason why we definitely should make the step to an EPD 2.0. The way I perceive it, I think in the last 2 or 3 years, everybody has realized we need to make this step. What's not so clear how this step should be done, and starting to try it out is definitely a good way forward. much better than writing some more studies. And with that, I'm really glad that you are actually taking this initiative, Ernst. So I think that's a very valuable contribution to make this very next step.
Yeah, and the open air movement has really gotten on the way. Also, thanks to you, and Swisscom is now behind it. And I got from Christian Westorff, I got a very clear statement that he and Swisscom sees open air as sort of the basis for an EPD 2.0. Because it's vendor independent, because it is human centered. You have to start at the with the personal data record and not with the clinical data warehouse, which is understandable that they will do that, but that I think this in our initiative with your help has really helped to connect the two dots, and maybe through the expedition we can test this also directly.
Just a few days ago, I was interviewed by a bachelor student who was working on the open air for the hospital of St. Gallen. So they're obviously also very active there.
Okay.
And they will join on next Monday's conference about open air. So we'll certainly have a chance to talk to them.
Okay,
so
cool.
We are coming to an end. Time is running out. It was extremely interesting for today. Thanks a lot for all of you joining us, Ernst, for sharing your ideas and your plans. I'm very keen to see how it's progressing. So thank you, Ernst, and we close this part now.